Good afternoon, and welcome to the Conversation Project, having the conversation about end-of-life care, personal and professional experiences webinar. Our presenter today is Dr. Gail Baraskin. Dr. Baraskin is a palliative medicine physician with Optio Health Services. She provides palliative care to patients and their families during acute hospital stay. Dr. Baraskin is also the medical director for the Denver Hospice Northeast team. She provides hospice care in all settings: home, inpatient, assisted living facilities, and in the long-term care communities. I'm your host. My name is Glenda Robertson, and I'm an instructional design developer for Colorado Access RCCO. Among my responsibilities are to develop information and learning technologies which inform members, providers, community resources, and other community leaders about RCCO, as well as being accountable for maintaining community engagement and the successful delivery of RCCO outcomes via education and communication efforts. Before we begin, let's go over some participation guidelines. Everyone is muted on the call, so that way, in case someone comes into your office or where you're watching this webinar, we won't be able to hear them. If you need to ask questions, please use the chat window. Note that you will only see your questions. You will not see all the participants, and I'm happy to say that this is going to be a very well-attended webinar. Thank you all very much for dedicating your lunch hour to this very important topic. If you have the raise hand feature, it will not be activated. And please note that after this webinar, you will receive an evaluation. We really do appreciate any feedback that you have for us, including what other webinar topics you would like to see in the future. Finally, a recording of this webinar will be placed on the Colorado Access RCCO website, Virtual Community for Collaborative Care, or VC3, at the link you see on the slide. The objectives of this webinar is, after this webinar, people attending will be able to describe the importance of having end-of-life conversations from personal, professional, and system perspectives, identify the barriers to having end-of-life care conversations, apply strategies and tools available to promote action, and to develop a conversation action plan that includes both a personal and professional conversation. And with that, I turn it over to Dr. Gail Baraskin.
Good afternoon, and again, I'd like to thank everyone for joining us on their lunch hour. Thank Colorado Access and Life Quality Institute, as well as the Denver Hospice and Optio Health Services for hosting and presenting this topic that I am very passionate about and think it's very important for us all to get comfortable with. So our agenda is going to follow the starter kit that Glenda referenced. So again, that starter kit is on the website www.theconversationproject.org. So in keeping with their setup, it's a get ready, get set, go, keep going. And since it's the lunch hour, I'm going to use the analogy that we're getting ready for a gourmet meal. So we are going to start with that and getting ready. So we're going to start preparing our food, chopping the vegetables, and let's get into what is the current standard in our community. But before we do that, we've got a couple of poll questions, and the first one is, do you have end-of-life discussions with your patients, members, and clients? And if so, how comfortable are you with having these end-of-life discussions with your patients, members, and clients? And I just want to say at this point, if I say patients, I am going to just know that it's all-inclusive for all of the folks that are attending this webinar. But if I slip into my provider role, I apologize. So the first question, do you have end-of-life discussions with your patients, members, clients? This is great. So the majority of us are at least most or some of the time, and then the rarely 11%. The question of how comfortable are you having the discussion? Just over half of us are very comfortable, which I'm very glad to see. And then we can see the results of somewhat a quarter somewhat, and then not very comfortable. So I'm hoping that after this webinar, we'll get everybody feeling very comfortable. And let's just talk a little bit about the Conversation Project. This is a campaign that started as a public engagement campaign that everybody has their end-of-life decisions expressed and respected, that it's rooted and grounded in our personal stories, and that we're going to change the cultural norm from not talking about this to talking about it, and everybody getting to that 100% of being very comfortable. This was co-founded by Ellen Goodman, and if you go to the homepage of the website, you can click and listen to a video of Ellen sharing some of her personal stories, and you can also get Ellen's background. Ellen worked for Newsweek, the Detroit Free Press, the Boston Globe. She won the Pulitzer Prize sometime in the 80s for distinguished commentary, and is a progressive columnist in social commentary. Based on Ellen's personal experience with her mom, as her mom aged, how important it was for her to have more in-depth, meaningful conversation. She talks about that, yes, her mom said, oh, I never want to be like this, just pull the plug, but that oftentimes it's the day-to-day decisions we make for our loved one, and it's the small decisions that add up that we've never really talked about, and that how she wished she had a more in-depth conversation. Let's talk a little bit about what's going on in Colorado with regards to the Conversation Project. Ellen Goodman was here last spring and talked at the Colorado Healthcare Ethics Forum about the Conversation Project, why she started it, and her passion for this. And it was at that time that a public campaign was launched of how do we bring this to the communities. And really, it's one of those topics that is kind of from the top and from the bottom, and we'll all meet in the middle because it's going to be multifactorial of turning this around. So I love this picture on the webinar. And one of the things that's happening, at least in the Denver metro community spilling out into Boulder County, is this notion of death cafes. And people coming together within their community to share not how they want to die, but how do they want to live. And I think that's an important way to approach our patients and members' clients is how do you want to live? How do you want to paint the picture of whether it's the last week of your life, the last year, and how do you want to share that information? So how do we want to prepare ourselves? Do we believe in an afterlife? What's our grieving rituals? And these are some of the things that are being discussed. I know some folks that are part of one of these death cafes, and this woman, she's in her mid-60s, and she wanted to have the conversation with her son, and her son wasn't ready, but she's ready, and she needed to find a community in which she could share her wishes. The other thing that I want to say as we're talking about Colorado is that, and we're talking about bottom up, top down. I just saw an article that Wisconsin State Medical Society has adopted and put in their strategic plan that every provider that has this conversation with their patient. And it's actually a PBS series, and it's going to be aired locally in Wisconsin and then nationally in September, so that may be something to look for. So again, small communities from the bottom up and from the top down. Good results. So where would you prefer to die? At home, in the hospital? I don't know. And I think these are important questions. And not surprisingly, the majority of us say at home. But let's consider the facts. So 70% of people say at home. We had about 85%. But that 70% of us die in the hospital, nursing home, or long-term care facility. And I'm going to just say a little personal caveat because I touch a lot of folks in the acute hospital setting. Weekly, I get consulted to see patients in the ICU who are intubated. And then I'm asked to come in a few days later. I'm talking with the families. They're upset. This is not what they would want, but that we all know there is a flow and energy into the emergency room, that when you're at home and families don't have the resources and patients and their loved ones are in crisis, 911's activated, and if wishes are not known, there is a whole flow that happens that most of us don't want. 60% of people say that making sure their family is not burdened by these tough decisions is extremely important, but that over half of us haven't communicated the end-of-life wishes. And so in that caveat that I just said about coming into the intensive care unit, the loved one is intubated and on life support, and now we're having to make some decisions around that the psycho-emotional burden is so enormous to family members around making those decisions. Let's keep looking at what the facts are in our community. 80% of people say that if seriously ill, they would want to talk to their doctor about end-of-life care, but only 7% have had the conversation with their doctor. And I would pause at this point because when I read this, I ask myself, what are the barriers here from a professional standpoint? And I have a lot of opinions about that. But some of the things that come to my mind right away is that for my colleagues who are based in the office, the visits are very short. They have to review medications with their patients, maybe blood sugars, what's their blood pressures, address the immediate concern of why that patient's there right now. You know, these conversations take time, and to fit them into our very busy regular patient slot visits is probably a huge barrier. And if we're not bringing it up, it might be perceived to the patient in the room that it's not important. I think the other big piece of this is also, these conversations take time, and that's not just one conversation. And how do providers, very realistically, how do they get reimbursed for their time? And I know there's some movement around codes around chronic care management, but I still think it's an issue. And, I think for some of us, too, and I think this has changed, but, when I talk to physicians in community, oftentimes that PTSD around that death panel rhetoric does still come up. And so how do we get past that? So, again, considering the facts, there's a big gap, as we've seen, between what people say that they should discuss what they would want at the end of their life, and that 9 in 10 Americans think it's important to have this conversation, but that only really 3 in 10 are actually completing that conversation. Again, some other barriers from a personal perspective, maybe having the conversation personally is this, and for a provider perspective too, is the comfort level. I am a little bit out of the academic world. I don't know what's being taught in medical schools. I know I'm not that old. I graduated medical school in 1993. This was not part of our curriculum on how to have these conversations. And so it becomes, are we comfortable enough having them? Not just professionally, but also personally. Again, noting time and busy schedules, And, you know, a lot of comments, again, I hear is, well, you know, we're healthy. Do we need to have this conversation now? I'm in my 40s. I don't have any medical problems. But I will just point out that this time last year, we had the very awful and traumatic experience at the Boston Marathon. And for those folks that were injured in that, they were probably some of the healthiest people in community since they were participating in the marathon. And were their wishes met when they were taken to the emergency room? So just something to think about. Again, in the hospital, some of the also some of the barriers that I run into are sometimes language, whether it's patients and families who are Spanish-speaking only, our Asian Pacific community. Recently, I had a Hmong family that I was dealing with. And, you know, oftentimes there is a family member who can speak English, understand English, and will offer to translate. And I'm not always comfortable with that. And there are professional translators in community to help overcome those barriers. But I know those can also be barriers. So, again, I think a lot of times, and we already talked about the too late, whether there's a traumatic event that happened and then we've never had the conversation, or people having so much discomfort around this topic that they just never engage in it. And it's always sort of that notion, well, you're healthy until you're not. And sometimes it can turn really quickly. And people can often sometimes be doing their normal daily activities, have a pain crisis, present to the emergency room, and are diagnosed with a stage 4 metastatic carcinoma. I see this all the time. And again, you're well until you're not. And so I think some of these conversations are happening too late. I love this next slide of the mom and daughter on the couch sort of looking at each other, who's going to initiate the conversation. It is hard to start this conversation on a personal level. You know, everybody has their maybe blips with their relationship with their loved one. How do you get over those blips to really get down to what would they want and not want? And on a personal note, and I just always find this fascinating, and I share this very often, about my mom is 85. 7 years ago, I had the conversation with her about what does she want and not want, and, you know, didn't have the template of the conversation project, and used the 5 wishes. It's just a template. My mom's very visual. She wanted to read something, and I didn't want to talk at her. I really wanted her to ask the questions and drive the conversation. And, you know, it started out awkwardly, and then she, you know, shared a lot of what she would want and not want. And about a week later, my sister calls me to tell me that my mom felt so empowered by that conversation. She felt like she had the permission to go ahead and make her funeral arrangements. I mean, my mom is healthy. She's well. She took care of something. That was certainly not my goal, but it really gave her some empowerment. I think this is the better setup to have a conversation, not on two ends of the couch, sitting down. He's drinking I'm going to assume some coffee. Maybe it's a cocktail you might need. Certainly not in our professional lives, but maybe at home that might help. And really having the beginnings of a conversation and not feeling like the conversation has to be completed in one session, but to actually just start the conversation. I say one of the facts, again, that I would share is that those who did have such a conversation considered their loved one's final days in a more positive light, having more of a positive experience because they knew their loved one was still in control and getting what they wanted. And that 63% say that they felt better knowing that they were honoring the wishes of their loved ones. And I think when, I wear two hats, and on the hospice end of this, we talk a lot about grief and bereavement, and that's a process for everybody. But boy, if you're doing what your loved one wanted up front, you can imagine that grief and bereavement process goes a lot smoother for the families. And that is ultimately, when we look at that burden slide, that burden statistic, what our loved ones would want. So the Conversation Project has a starter kit that we can all use professionally and personally. This is what it looks like. Again, it's at theconversationproject.org. So let's keep going through this. This is the home page. You can see the video of Ellen Goodman in the bottom left-hand corner. If you put your cursor over some of these other individual photos, you'll get the little personal stories of each of those folks that are pictured there. So what's their strategy? Again, working with states, counties, and cities, so we can see going from macro to micro. They have the monthly newsletter and the call for the Conversation Project in communities. Sharing what's working and what's not working in our communities. What are some opportunities? As you dig deeper into the site, you can read about what's happening in different communities throughout our country. Boston hosted a faith-based initiative to get their spiritual members to start having the conversations. There was a death over dinner engagement earlier this year, and really just trying, again, in all ways, all creative ways, to be a catalyst for the change and to change the norm from not talking to talking. There is a universality of this issue. It touches all of us who are listening today from a professional perspective, but also all of us on a personal level. So the findings thus far from the Conversation Project, they have found that having the conversation makes a major difference in people's lives. Not every conversation is perfect, maybe a couple of starts and do-overs, and that it's not just one conversation, but multiple conversations over time, and that maybe that conversation changes from when you're in your mid-30s to starting your families until when you want to age in communities. So it's something that morphs. It's not set in stone. And then the impact on healthcare providers. I think as providers in the community, however we touch patients, we need to give them permission to our patients to have the conversation and to let them know it's important to us. They're not wasting our time, that we're taking them seriously. Some examples that have been shared with me is people in family practice making it part of their wellness exam. Making time for a follow-up visit to discuss it. So it's not just here's a piece of paper, fill it out, and we'll put it in your chart, but let's sit down and talk about this. And I think we need to put the emphasis on the importance. So when you dig a little bit deeper into those personal stories on the home page, the question is, what do you want your death to be like? In these next series of slides, nobody is saying, I want to be in the hospital with multiple tubes, lines, and 5 medical specialists on my case. So some of the personal stories are, I want to say goodbye to everyone I love, have one last look at the ocean, listen to some music, and go. A tingling sensation of sadness combined with gratitude and overflowing love for what I leave behind. Paced, and with enough space and comfort so that I can make it a quality chapter in my life. I want time and help to finish things. What do you want your death to be like? Peaceful, pain-free, with nothing left unsaid. And so I pose the question, what do you want your death to be like? If you haven't thought about it, it's not something I talk a lot about, but that's because it's kind of a professional hazard, and everybody around me knows exactly what I want and don't want. But I think, again, it's an important question that we need to pose. I think we'll pause at this moment and see if there's any questions that have come in. Glenda, any questions?
If you have any questions, go ahead and type them into the chat box. Excuse me, into the chat box. But I can tell you so far there are no questions that have come in.
Okay, well then we'll keep going. If you have questions on this first part, feel free to put them in the chat box. We will have other pauses to go over questions as we continue. So following the starter kit, we're at Get Set. So we're going to set the table. Is it easier to have the end-of-life conversation with your patient, client, member when he or she is healthy or sick? And we'll see what we all say. So when they're healthy. And again, while you may have that barrier of talking about something like this when somebody's healthy, I can tell you, and I'm sure that most of you experience this, is that when you're sick or there's a crisis, nobody's making good decisions. Patients aren't, families aren't, and certainly providers may not be making the decisions that the patient wants. I want to also make a comment before we talk about this next slide, is that it's important that we do this for our children. I think, again, there's a momentum that happens with children when they're chronically ill, and that the parents need to take the initiative to do this for their children. And of course they need to do it in an age-appropriate manner. If you have a child who's 3 to 4, you're going to be really making all the decisions for them. But if you have an adolescent, maybe a 14-year-old, they can certainly participate in a lot of this. So making sure that, we have age-appropriate conversations with our kids. So in the starter kit, and I believe it is page 3, and part of that getting set is defining values. What matters to you most? What matters to you now? What are your values now? What would matter to you at the end of life? Again, we sort of saw those screenshots earlier about what people, who have really put the thought and intention into this about what their final days would look like. So that is part of the starter kit. Again, we'll pause for some questions.
A question did come in. The question is, I work at a cancer center. I'm concerned that if we bring up what do you want your death to look like, the patient might think they're dying on the first visit. When would be the best time to bring up this issue when a patient is first diagnosed with cancer?
So that's a great question. And I think when patients are first diagnosed and they're starting to go through this process, and I think rhetoric is important here and semantics. So it may not be what do you want your death to look like as they're making a decision to go through aggressive treatment, but to talk to them about, have you thought about what's important to you, and using the language to really put them, do you want to stay in control of your healthcare decisions? How much do you want to be in control? Is there somebody else you'd rather have make those decisions for you? If you want to be in control, what's important to you? You know, when I come in and meet patients and families, I typically don't say, I'll introduce myself that I'm the palliative care consultant. And it brings up a lot of questions, and a lot of people think they're immediately dying. But my 3-second elevator speech is, I'm here to talk to you about symptom management and goals of care. And I think, finding the language, what's ever comfortable for you to use with your patients in this situation is, do you want aggressive symptom management? Is pain control important to you? What are your goals? If the goal, and to start the conversation there, I don't think, I would imagine that most of those folks will be relieved that somebody is talking to them about this. And that it takes a team. It may be the social worker in the cancer center to help. Maybe it's the nurse who's at the bedside or at the chemo side doing the infusions that has the best relationship. You've got to find whom in your center is most comfortable and how they can broach this conversation. Did I answer your question?
Well, that was awesome. And we have another one that came in.
Okay.
What sort of responses have you experienced from the various faith communities?
That's a great question, and it can vary depending on what the affiliation is with the patients and families that I touch. I think that the overwhelming majority are on board with having a discussion. And the discussion may be, the end of the conversation may be, life at any cost is what's important to me. Well, then those are the folks that we may be treating differently, and families need to know that. We need to know that as providers. But I would say that the overwhelming response from the faith community, sometimes they're relieved because we're having the conversation and they don't have to. A lot of support when they're coming into the hospital to serve their clergy member. And I don't find a lot of resistance. I find a lot of support or curious questions, some curiosity about how they can bring this back to their membership.
And that's all the questions so far. Thank you, everyone, for great questions.
So going on, we're on go, so we're going to serve the meal, again, following the starter kit for those of you who have it in front of you. So the go portion of this is, who are you going to share this with? Your doctor, your partner, your parents, your children, your best friend. I gave that example before of the woman who I know who's involved in one of these death cafes, that she's looking to her community of peers. That's who she feels comfortable knowing. And it's sort of a who, what, where, when. Where do you want to have the conversation? Do you want to have it in the car because that's the easiest place to have the conversation? Do you want to have it over dinner? Do you want to have it at home? And when? When is, I think, is important because this is going to take time. This is not a even on a personal level, not a 10-minute discussion. And are you going to have it at night after, a Wednesday night, the middle of the week, a long work day, you've got a meeting the next morning, or are you going to do it on Sunday afternoon, maybe outside at a picnic? I mean, there's no right or wrong answer, but I think, it's setting it's really setting that table and setting it up for the best possible outcome. And I think we're at another question slide, if anything's come up.
Nothing has come up so far.
Okay. So, again, I've said a couple of times, it's starting the conversation and then probably having it multiple times, and maybe that conversation changes. So the keep going part, this is what I'm going to call dessert. So you've had the conversation, you've made some choices, either personal, with family, with your patient, your members, your clients. Now what do we need to have in place to ensure that those wishes are going to be met? And so I'm going to change a little bit this slide. This slide comes right from the Conversation Project Starter Kit, but I'm going to make it specific for what we have here in Colorado. So the first bullet point, healthcare planning, that's what this is. This is the conversation, the starter kit. That is healthcare planning. You're talking about your wishes and you're making them known. What I'm going to put in, let's skip bullet 2 for a second and go to bullet 3 that says healthcare proxy. And what I would like everyone to do, if you've printed this out or you're taking notes or you've got the starter kit, is to cross that out, because the language we use here in Colorado is medical durable power of attorney. And that is the most important document that our patients, members, clients, family, ourselves can have. What that is a document that when the patient has, or the person has capacity, that they can appoint the person that they want to make decisions for them. If they can't, which is one of the options, or sometimes people choose that even though they maintain capacity, that they still are turning over all the decision making to their MDPOA, and that's a personal choice. And that often is influenced by kind of cultural norms within those patients' communities. It is the MDPOA that is the most important document. The patient needs to make sure that they tell the person that they're their MDPOA, and that person should be the number one person that they've had the conversation with, because it's really that can drive and really have the positive outcome for that individual to make sure that their wishes are met. When, again, I'm going to just talk about my experiences. When I come into the hospital, I always check, is there an MDPOA? Are they present? And have they had the conversation? And if they've had the conversation, for them to tell me, well, what did your loved one say? Not what do they want. You know, they're scared, they're upset, they want their loved one to live, but at what cost? And I need to know what was the conversation and what did that patient, and what was the heartfelt wishes of the patient who can't speak for themselves. So that's the number one important document. It doesn't need to be notarized. It is a very simple document to fill out. The advance directive, how is often interpreted in our community as the quote-unquote blue form, or the CPR form, or the DNR form, the no cardiopulmonary resuscitation form. And if that's what folks want, if they're that, you know, if they've made that decision, I think that's an important form for us all to have, to provide that to our patients and members and clients. We also have here, that's not listed on this page, in Colorado, the MOST form, which stands for Medical Order Scope of Treatment. It is most commonly seen in our long-term care facilities and in our assisted living. It is a medical order set. It is medical orders to be put on the chart for the nursing staff to follow. And what it addresses is, does this patient want cardiopulmonary resuscitation? Do they want to go back to the hospital for continued aggressive treatment, or do they want to stay in place and be kept comfortable? Do they want antibiotics? Do they want artificial nutrition or hydration? And this is again, a discussion to be had with the patient if they're able and they have capacity, or with their appointed designated MD, POA, or guardian. And that is, again, a medical order set that needs to be signed by a healthcare provider. The last bullet point here, the living will. I have sometimes problems with living wills, and the problems I have is that it is a legal document, and they're often templates, and there's not a lot of that patient's wishes and desires brought into the living will, unless that individual has sat down and crafted their own wishes themselves. It's typically template. It's a checkbox fashion that you initial, and it's always a lot of the extremes. And when we talk, going back to what we initially said, most of us will say, oh man, if I'm on life support, pull the plug. I never want to be like, that patient who's the latest news story. But it's those little decisions over years sometimes. When we look at our elderly population with end-stage dementia, that families over years have to make multiple decisions, not the pulling the plug decisions, but do we take them back to the hospital? Do we do a bone marrow biopsy to find out why they're anemic? All those other pieces. And again, in Ellen Goodman's video, I think she shares her own personal struggles with this, that is what we need to know about. And those things are no way addressed in our typical template living wills. So just sort of some of my thoughts around the living wills. I think they're important for your legacy. I think they're important for financial things, but for our medical decisions, I think having something like the Conversation Project, having the conversation, and then the medical durable power of attorney are probably the two most important things. So what are some of the professional barriers that you face? I think this is an opportunity to put in the chat box. Would like to I've shared a lot of some of the barriers that I've perceived. Would like to hear from the community.
Go ahead and share with us some of your professional barriers that you face. Put that in the chat box, and we'll talk about it here in just a moment. So I think while we're waiting for folks to type in the barriers that they professionally face, I'm going to ask a quick question.
Yes, please.
A question about the MD-POA came in. And it was, I was not surprised to hear you say that the MD-POA does not need to be notarized. However, my training in facilitating these documents was that it does need to be notarized. The current Colorado form we use in the hospital does have a notary section at the end on page 2. Please clarify.
So I'm wondering if you have the old forms or the new forms, because the forms that I have filled out personally for myself, as well as for our patients in the hospital, does not have a notary section. This is an official notarized, the notary stamp. There are signatures, and that needs to be witnessed, but it doesn't need to be notarized, not for a medical durable power of attorney. So that's all I could say is that's my experience. And it says that you have the new forms, but again, it's not a notary signature. It needs to be a witness signature, so nobody has to come up with the stamp. So what are our next steps? What do we do now? What can we do by next Tuesday? If we work in offices like the woman from the Cancer Care Center, do we want to have a small little action committee of how do we start doing this for our patients? Is that our next action plan? Do we want to just simply download the starter kit to have it available for our patients and members and clients? Do we, again, want to start putting on our calendar, when do I personally want to have this conversation? What do I personally value and believe? You know, a lot of us don't even think about it. Who are we going to share it with? Are we going to download this and link it to, like, you know, everybody in our family and everybody on Facebook, and that would be great, in my opinion. And are we going to share our own stories on the Conversation Project website? And again, there's the link to the website at the bottom of the screen. And I think the big thing for the providers out there is how are we going to integrate this into our very, very busy practices, and how do we start getting comfortable with it? So how comfortable are you having the end-of-life discussion with your patients, members, clients? So I think we can compare this to the beginning, that for some folks that we had a small percentage that was not comfortable, at least we've got everybody over to the somewhat or very. And I think, again, while it's the beginning of the conversation that we have, that this is not something that necessarily you feel comfortable with in one webinar with one look at the Conversation Project Starter Kit, that this is something that takes time and practice. Again, are there any other questions that came in?
A comment more than a question came in about the MDPOA. The MDPOA form I downloaded from the Colorado Advanced Directives website states that 2 witnesses or notarized has to be a section, and it was downloaded about a month ago.
Okay, and so thank you for clarifying that. And I guess what we typically do in the hospital setting when we're having these conversations and people don't have their MDPOAs, we usually have the 2 witness. So I think, thank you for whomever sent that in to clarify. So you can have 2 witnesses, and we typically get the patient representative in there to witness, and somebody else who's not part of the medical team to be the witness. And then you have the option also for the notary. But I guess sometimes for us, having a notary is a barrier. If I'm having this in this conversation in my office, and somebody has their loved one there and they want to complete an MDPOA, you know, maybe every office now has a notary in there, but if not, you don't need that, and it just needs to be witnessed. I do know that the physician cannot be a witness on the MDPOA, but you can certainly grab your front office staff or one of your back office people. But thank you for clarifying that. I appreciate it. Any other questions, Glenda?
Let's see. Does the person designated to be MDPOA need to be present?
So I'm not sure how to interpret that. Present at the signing of the MDPOA or present in making decisions? I know oftentimes they don't need to be present filling out the form. So, okay, so the clarification was, do they need to be present at the signing? They don't. There's not a signature line for them accepting it. Typically on the form, if I've got my mental camera going right, you can have your first contact, your second contact, or co-MDPOAs. Obviously, we need names, phone numbers, contact information. A lot of times we don't have people present when we're filling these out. They may be on the phone while we're doing the consult. Or they're coming in later and we're just trying to get the paperwork done. The big thing is if the patient's driving this because they still have capacity and we're filling out the form, that they're telling these people who they've designated that they are now an MDPOA. So, and oftentimes in the hospital, we're following, the case managers are following up with the MDPOAs, the appointed MDPOAs, to say, are you going to accept the responsibility? So, that loop is closed. But from an office setting, they don't need to be present, but you need to encourage, again, your patient or client that they need to make sure they have the conversation with this person and that they know that they're designated.
Another question is what if the MD-POA refuses to serve in this capacity when needed? What happens when the patient has not designated an MD-POA?
It's a great question. So if the person refuses to be MD-POA and the patient has capacity, then we need to go in and help them kind of do a life survey of who else are they going to feel comfortable making the decisions for them. So, again, that's a team effort. That's me as the physician, the other folks on our team at the hospital to help that patient navigate when and this comes up. This definitely comes up when someone's like, I'm emotionally can't do this. I can't, and they'll tell, a lot of times they'll tell the patient, sometimes they tell us, and then we have to tell the patient, and then we help negotiate that. If a patient does not have capacity, and there is no MD-POA paperwork done in the hospital, and I can only talk about how, it should be standardized. I can tell you how it's done in the hospital that I provide palliative care consults in. When somebody comes in, they don't have capacity, whether it's because they're end-stage Alzheimer's or they're now intubated, for whatever reason, they don't have capacity, they don't have MD-POA paperwork, and difficult decisions need to be made. The onus falls on the case manager at that point. There's typically people who are identified as interested parties, whether it's the people who brought them into the emergency room. And then what they have to do is call all interested parties, so maybe it's an extended family or, whether it's their sons or brothers and sisters or whomever. They have to call what we call interested parties and find somebody that will be willing to be the proxy decision maker. And everybody of these interested parties has to sort of agree that, yes, the brother's the best person to be the proxy decision maker. And that process is only good for that admission. And so you can see by not having this paperwork done how onerous that could be, because that proxy, every time that patient comes back into the hospital or they go to the next level of care, that proxy has to be readdressed. So that's what happens when folks don't have an MD-POA, and you can see if we're in a do we intubate or don't we intubate sort of situation in this crisis mode that we often operate in the hospital, you are intubating because to do this proxy takes some time. So, and that may not be what that patient wanted. We don't know.
Our final question for today is, how do you know if, since patients can redo their MD-POA at any time, how do you know which one is the most current or if there are other versions in circulation?
Yeah, and that's a great question, and I bumped into that a couple of times. There's typically a place to date the MD-POA form. So whatever's the most recently dated is typically what we go by. With that said, you can imagine there may be a little bit of psycho-emotional strife within that circle of people. And so we try to be inclusive yet respectful of what the most current document is, and to make sure that that most current document is a legitimate current document. So again, if the patient has capacity to confirm with that patient, is this the most current document? Is this your current wishes? If they don't have capacity, we're questioning the validity of that document, it might take some navigating through. I hope that answered the question. I'd like to say thank you for sharing your lunch hour with Glenda and myself today, talking about what, again, I think you have gotten the feel for, that I'm a topic I'm very passionate about, and that we all in some way become foot soldiers in changing this cultural norm and starting the conversations within our own communities. So with that, I will say thank you.
Thank you for participating. And again, remember, a recorded version of this webinar will be on the RCCO website at vccc.co. Thank you and have a great day.